pediatric IOL calculation and visual rehabilitation in pediatric cataract cases with Dr. Amr Abdulaziz. تفضل دكتور.
السلام عليكم ورحمة الله. المحاضرة تعتبر تكملة لمحاضرة الدكتورة نهال. هنتكلم شوية عن ال Pediatric IOL calculation والvisual rehabilitation post operative. هذا. So first IOL implantation pediatric cataract surgery. أنا عملتها على شكل سؤال وجواب بحيث تكون أسهل وأسرع إن شاء الله عشان الوقت. So most significant areas of debate in pediatric cataract surgery and IOL implantation decision. إيش أكثر الأشياء اللي في عليها debate والنقاط اللي فيها اختلاف عن adult cataract surgery. First, timing. When to implant IOL in pediatric cataract surgeries. Whereas to do only cataract surgery, lensectomy, or to implant IOL primarily. And what is the IOL power, the target refraction, IOL type, and optical rehabilitation. So first of all, when to implant IOLs in pediatric cataract surgeries. Laterality is very important point that will help you in deciding when to implant the IOL. So if you have unilateral cataract surgeries, you can implant IOL as early as 7 months old, according to infant aphakia study. Even some surgeons, they implant earlier than 6 months, but as Dr. Nihal mentioned, the changes in the corneal curvature and axial length during the first 6 months of life is huge. And you will face a huge myopic shift that is unpredictable, and it can lead to amblyopia after that. In bilateral cataract surgery, you can implant IOL as early as 1 year of age. Also, ocular comorbidities will help you in deciding whether you can implant or not. For example, if the patient has microcornea, which is less than 9 millimeters, you cannot implant IOL. Also, if the patient has axial length less than 17 millimeters, and if the patient has anterior segment dysgenesis or pre-existing glaucoma, all these factors can make IOL implantation has many complications for the patient. IOL power, target refraction. There are two methods that can help you in deciding what IOL power to implant in the pediatric cases. The first one is the target refraction equals 7 minus the age in years. For example, if you have a child who is 6 years old, so you will the target refraction will be 7 minus 6. That is, you will put +1 under correction. Then if the child, for example, is 2 years old, then you will do 7 minus 2, that is +5 under correction. So if the emmetropia is +30, you will make it +25, for example. The second method to undercorrect is the percentage. So if the child is 1 to 2 years old, you can do 20% undercorrection. If he's 2 to 3 years, you can do 15% undercorrection, and so forth. But put in mind that all these are just guidelines. Personally, I do the both methods in each child, and then I will take something in between. Okay. This is something quoted from Edward Wilson, Pediatric Cataract Surgery book. He said these tables are only meant to be as a help as a straight point toward appropriate IOL power selection, which is multifactorial decision and customized for each child based on many variables: the age, laterality, amblyopia status, likely compliance with glasses, and family history of myopia. All these factors will help you to decide what is the target refraction for the child. Come to which IOL and what is the IOL type. For rigid PMMA is the best and the only choice. For foldable, actually the best choice for children is the acrylic hydrophobic IOLs, which is unfortunately in Yemen, like only maybe one company has hydrophobic acrylic. All the other companies has hydrophilic. Hydrophilic will cause more PCO rates, will cause more phimosis, will cause more capsular contraction because of the biocompatibility of the lens. So why acrylic hydrophobic? It has good UVL, excellent capsular biocompatibility, folds, unfolds in controlled fashion, more than hydrophilic. Hydrophobic will unfold very fast and very low water content and high refractive index. Coming to the IOL types, we have two types, single piece and multi-piece. For in-bag implantation, you can whether use single piece or multi-piece. But for sulcus, please only implant 3-piece IOL. Please only implant 3-piece IOL. If you are implanting foldable single-piece IOL in the sulcus, it will move. In many cases, it will move with the pupillary dilatation. Pupil will move, and the IOL might be decentered. 3-piece IOL usually will be more stable. Coming to post-operative visual rehabilitation, aphakic glasses. In aphakic patient, you should do refraction as soon as possible. I saw some children that had done lensectomy, and the surgeon told them to come after 1 month for refraction. That is too long. You have to do post-operative refraction as soon as possible. Within 1 week, you need to give these glasses, aphakic glasses. Otherwise, you will help him in like preventing deprivational amblyopia, and you will put him in emmetropic amblyopia. So he will not gain any benefit from the surgery. Once you do the surgery, give him 3 to 5 days until the cornea clears. If you put air bubble, it will absorb. Then directly do refraction for the patient and give him the aphakic glasses. Usually put in mind, those children has no accommodation. So we need to give the full refraction. And in 1 to 2 years, we need to give the refraction plus 3 diopters. For 3 to 4 years, you need to give plus 2, and 5 years or older, you need to give bifocal glasses. Post-operative visual rehabilitation. Patients who are pseudophakic, you should do refraction as mentioned as possible as after surgery. Again, when you are giving the glasses, put in mind, those children has no accommodation. Those children has no accommodation. They are not like normal children. You will give 2/3 of the refraction and so on. No, give full refraction. If he has +5, give +5. Do not undercorrect. That patient is just like an adult who is 60-year-old. He has no accommodation. Post-operative rehabilitation, the follow-up usually in pediatric cataract surgery, it's not like adult cataract surgery. You need to see the patient first day post-op, first week post-op, first month post-op, then every 2 to 3 months in the first year post-surgery, then every 4 to 6 months, and for a very long-term follow-up, because those patients has a risk of post-operative pseudophakic or aphakic glaucoma even after 10, 15, 20 years post-surgery. Those patients has a long-term risk of developing retinal detachment and glaucoma. You can see even the child more often in complicated cases or in cases of severe post-op reaction. What to do in the follow-up visit? You need to check for visual acuity, visual axis obscurations. You need to check the IOP, check the refraction, check the fundus, check the visual acuity or the fixation of the patient, and check the compliance for the amblyopia therapy. It's very important point. Very important point, especially in unilateral cataract cases. You need to put the child in an aggressive amblyopia therapy. Patch the normal eye 6 to 8 hours and check the compliance with the family in each visit. Otherwise, you will have a great surgery and very good surgery, but very poor visual outcome. Amblyopia therapy in unilateral cataract cases need to start occlusion therapy as early as 1 week post-op. Start with aggressive patching regimen and check compliance each visit. In bilateral cataract cases, when fixation preference is present, for example, patient has bilateral cataract and you did bilateral cataract surgery, but he came to you after 2 or 3 months with right esotropia or right exotropia or unmaintained fixation on one of the eyes. That will give you a hint that there is one eye which is amblyopic more than the other eye. So you can also start patching.
Still 1 minute, Dr. Amr.
Biometry formulas that we use, unfortunately for pediatric cases, there is no specific IOL formula, but and errors are common. Haigis-Hofer formula for smaller eyes, and some surgeons prefer using SRKT for all the eyes. Challenges in biometry key reading using standard autorefractometer. Sometimes it's not easy for younger children. You need to use a portable autorefractometer. Further reading in pediatric cataract surgery, I would recommend 3 books that are very important pediatric cataract surgery for anyone who is doing pediatric cataract surgeries and who is interested in that field. That book, Pediatric Cataract Surgery for Mr. Edward Wilson, one of the most important books, Pediatric Lens Disease and Essentials of Pediatric Cataract Surgery by Coker. For those who love to watch videos, you can watch Dr. Nihal Shaqantiri video on cyberside.org. She has a very nice presentation for 1 hour about surgical management of congenital cataracts. And there are other lectures like Pediatric Cataract Dilemmas by Ramesh Kekunaya and Pediatric Cataract Management by Dr. Kalyani from Shankara Netralaya. Thank you so much.
شكرا دكتور عمرو. هلا الاسئله نخليها لنهايه السجن علشان الوقت بس علشان صلاه الجمعه. ننتقل لل other topics with pupilloplasty pediatric traumatic cataract.